Hello and welcome. My name is Drew Stivers, and I've shared a short summary of my professional background at the end of these slides. The title of this presentation is The Use of Technology Data to Identify Medication Safety Risks. This is the relevant financial relationship disclosure for this presentation. This is the learning objective that will be addressed during this presentation. These are the key abbreviations that will be used in this presentation. Finally, before we begin, here is a self-assessment question. We will return to the self-assessment question at the conclusion of this module, and I'll provide an answer and discuss the rationale. As discussed in the previous module, the ASHP's statement on the role of the medication safety leader provides an outline of medication safety leader responsibilities. A core focus of this statement is that medication safety leaders play a critical role in the planning, development, review, and evaluation of an organization's medication safety plan, a process that requires a deep understanding of risk concepts and prioritization to minimize patient harm. As leaders, it's critical that if we're to lead these efforts, we must develop not only an understanding of how to recognize risk, but also strategies for how to do that. In this module, we'll focus on the use of medication use technology data, demonstrating examples of how those data can be used to assess risk and used to demonstrate the effectiveness of medication safety initiatives. Listed here are some examples of both reactive and proactive risk identification methods that were presented in the intro module and will be covered in further detail. Some examples of reactive risk identification methods that are covered in dedicated modules that are part of the Medication Safety Certificate program include medication error reporting systems and root cause analysis. During this module, we will focus on the use of data abstracted from multiple medication use technology sources to showcase how those data can be used to identify risk. We'll explore the use of trigger-based risk identification methods and highlight these points with an example of ADR data to reinforce the concept of reactive risk identification and how that can fit into a broader strategy for medication-based risk identification. To begin our discussion on the use of technology data in medication safety, let's start by looking at this visual representation of the MedUse system. Technology and automation are deeply embedded in healthcare, with increasing adoption at every phase of the MedUse process. From electronic prescribing systems to automated dispensing cabinets, BCMA, and smart infusion pumps, these tools enhance efficacy, reduce errors, and improve patient outcomes. Studies have shown that technologies like CPOE with clinical decision support can significantly reduce prescribing errors, while BCMA has been associated with substantial decreases in medication administration errors. As technology continues to evolve, its integration across multiple phases of this medication use system is helping to create a more seamless and data-driven approach to patient care. Technology and automation are among the highest tier interventions for preventing harm. The Institute for Safe Medication Practices and other patient safety organizations emphasize automation as a key strategy in reducing medication errors. However, there's also a flip side to technology in healthcare. As much as it helps to mitigate risk, it can also introduce new challenges and unintended consequences. Automation complacency, where users become over-reliant on technology, can lead to errors when system alerts are overridden or ignored. Poor system design and workflow integration can also contribute to errors, as seen in cases where EHR alert fatigue leads to clinicians dismissing critical warnings. Understanding and mitigating these risks is just as important as leveraging technology's benefits. For today's discussion, we'll focus on three key phases of the MedUse system: prescribing, preparation and dispensing, and administration. Each of these phases involves various technologies that generate vast amounts of data. The ability to collect, analyze, and act on these data is one of the greatest advantages of automation. For example, dispensing data from automated dispensing cabinets can help identify patterns of medication diversion, while barcode med administration data can reveal trends in administration timing errors. Harnessing these insights allows us to move beyond reactive error reporting and toward more proactive risk mitigation. Throughout this presentation, I'll highlight specific examples of technology-generated data that you might consider when developing your risk identification plan. By leveraging these data points, we can take a more objective and targeted approach to reducing medication-related risks and ultimately improving patient safety. One of the key ways technology supports medication safety is by improving efficiency and reducing prescribing errors, and CPOE is central to this effort. By replacing handwritten orders with electronic entry, CPOE reduces the risk of misinterpretation and transcription errors, while also enhancing workflow efficiency. But beyond simply digitizing the prescribing process, CPOE has introduced several safeguards that directly address long-standing medication safety risks. For example, CPOE systems guide and even enforce the selection of appropriate dosing units, dosage forms, routes, and frequencies. This ensures that prescribers are choosing from standardized options rather than entering free text orders, which can lead to variability and potential errors. Additionally, pre-populated order sets help standardize prescribing patterns based on clinical indications. By incorporating evidence-based guidelines, these order sets ensure consistency in how medications are prescribed for specific disease groups, reducing the risk of inappropriate therapy. Another critical feature is dose rounding and standardization, which are seamlessly integrated into CPOE systems. This helps to ensure that doses align with established best practices, making administration safer and more predictable for both patients and providers. CPOE also offers real-time alerts and clinical decision to help aid clinical decision-making. These alerts may flag potential drug interactions, allergies, or contraindications, helping prescribers make safer choices at the point of entry. While alert fatigue is certainly a concern, well-designed systems focus on high-value, actionable alerts to guide best practices without overwhelming clinicians. Beyond prescribing decisions, CPOE also plays a vital role in streamlining communication within the electronic medical record. Providers across different departments or care settings can easily access and review patients' medications histories, ensuring continuity of care and reducing the risk of duplicate or conflicting medication orders. Another major advantage of CPOE is how it drives formulary standardization. This includes therapeutic interchange protocols and prescriber restrictions, ensuring that medications are prescribed in alignment with institutional policies and best practices. Standardization at this level not only promotes cost effectiveness, but also enhances patient safety by reducing variability in prescribing habits. And of course, one of the most fundamental safety improvements is the elimination of illegible handwriting. With CPOE, every order is clear, reducing the risk of misinterpretation that could lead to a serious medication error. Building on our discussion of CPOE, another key component that enhances its effectiveness is clinical decision support, or CDS. CDS is a broad term that encompasses a wide range of tools and interventions designed to assist healthcare providers in making informed, evidence-based decisions at the point of care. Within CPOE systems, CDS includes features such as computerized alerts and reminders, clinical guidelines, pre-built order sets, patient data reports, dashboards, documentation templates, and clinical workflow enhancements. Each of these elements plays a critical role in guiding prescribers, streamlining processes, and ultimately improving patient safety. When we narrow our focus to medication-related CDS functions, these tools directly support safe prescribing and reduce the risk of adverse drug events. Some of the key medication-related CDS features include allergy checking, which automatically alerts prescribers if a patient has a documented allergy to a prescribed medication. Dose range checking, which ensures prescribed doses fall within recommended therapeutic ranges based on established guidelines. And this is particularly crucial for high-risk medications, such as anticoagulants or chemotherapy drugs. Duplicate therapy checking, which flags scenarios where multiple medications with similar therapeutic effects are prescribed, reducing the risk of unnecessary polypharmacy or unintended therapeutic duplication. Interaction checking, which includes drug-drug, drug-lab, and drug-disease state interactions. These checks can help prevent prescribing errors such as contraindicated combinations, inappropriate medication use with the certain disease states, or drugs that require monitoring due to lab value abnormalities. And finally, advanced dosing guidance, which takes into account patient-specific factors like age, weight, renal or hepatic function, fluid status, or cumulative lifetime dosing. This functionality ensures that dosing adjustments are made based on individual patient characteristics, helping to optimize efficacy while minimizing toxicity. When implemented effectively, CDS doesn't just provide passive information, it actively shapes safer prescribing patterns. However, it's also important to acknowledge that CDS must be well calibrated to avoid excessive alerts that lead to alert fatigue. The goal here is to provide high-value, actionable interventions that meaningfully enhance clinical decision-making without overwhelming prescribers. While CPOE and CDS systems play a critical role in improving medication safety, they also introduce new risk factors that require monitoring. By leveraging data from these systems, we can identify potential vulnerabilities and refine processes to enhance patient safety. Listed here are some key opportunities for risk identification. And while this is not a comprehensive list, it does provide a pretty good overview of some areas that you might consider focusing on. The first is an audit of missing information. One common issue with CPOE systems is that there's incomplete or missing information within medication orders. A classic example here might be allergy documentation, where if allergies are coded as free text instead of structured hard-coded entries, CDS systems may not accurately recognize and flag potential allergy-related interactions. A regular audit of free text allergies might help to uncover gaps and drive improvements in data entry standardization. Another area of focus might be on utilization of pre-populated or default orders. Pre-populated orders and order sets are designed to enhance efficacy and drive standardization, but their utilization should be assessed to ensure they're being used correctly. For example, sepsis order sets can drive timely and appropriate antimicrobial therapy, but if clinicians frequently deviate from them, it might indicate workflow misalignment or the need for education on best practices. Evaluation of alert overrides and alert fatigue metrics is a good way to assess your clinical decision support. CDS alerts are meant to prevent errors, but excessive or low-value alerts can lead to alert fatigue, where providers reflexively dismiss warnings. By tracking override rates, we can evaluate whether alerts are too frequent, poorly designed, or clinically irrelevant. MAR documentation is another area where audits can be performed to look at for risk identification. MAR documentation audits can help identify inconsistencies in medication administration. For example, time-critical medications such as insulin or anticoagulants dosed using nomograms and protocols require precise timing and adjustments. If documentation reveals delays or inconsistencies, this may indicate workflow barriers that need to be addressed. Omitted doses is another area where tracking dose administration might help identify potential gaps in medication administration. For instance, non-administered doses of venous thromboembolism prophylaxis in hospitalized patients or missed supportive care medications like growth factors in an ambulatory oncology clinic can increase the risk of patient harm. By analyzing these data, we can uncover patterns and implement corrective strategies. Medication monitoring documentation is also another area of audit opportunity. Effective medication monitoring ensures patients receive appropriate follow-up for high-risk therapies. This includes tracking whether required lab values or assessments are documented and reviewed. Failure to monitor drugs such as anticoagulants, antimicrobials, or other nephrotoxic medications can lead to preventable adverse events. And finally, pharmacist interventions. Pharmacists play a critical role in identifying and mitigating medication-related risks. Many electronic medical record-based pharmacist interventions contain valuable insights into prescribing and administration patterns. By merging these pharmacy interventions with other incident reporting that occurs through your safety event reporting, we can develop more comprehensive understanding of medication safety trends and areas for process improvement. Ultimately, CPOE and CDS offer a wealth of data that can be leveraged to identify and mitigate medication safety risks, and by systematically analyzing these areas, healthcare teams can proactively enhance prescribing, administration, and monitoring practice, which lead to safer and more effective patient care. Automated dispensing cabinets have become a standard of care for medication distribution within health systems, playing a vital role in improving medication safety and efficiency. These systems are used across multiple clinical care areas, including inpatient units, emergency departments, operating rooms, and ambulatory clinics. ADCs offer several advantages and safety benefits that ultimately enhance patient care by streamlining medication storage, retrieval, and administration. Let's break down some of the key ways that ADCs contribute to a safer and more efficient medication use process. First, ADCs enhance the efficiency and accuracy of medication dispensing through mechanisms like locked lidded bins, which prevents access to multiple medications, which in turn minimizes the potential for wrong drug selection due to human error. And also the use of profiled cabinets, which integrates CPOE systems and pharmacy verification systems, ensuring that only medications linked to an active, verified order are accessible. This connectivity reduces the risk of unauthorized medication retrieval and enhances coordination across the medication use process. These features and others contribute towards supporting medication storage and security standards. ADCs contribute to compliance with medication storage and security regulations, ensuring that medications are stored in controlled environments and accessible only to authorized personnel. This is especially important for controlled substances, high-cost medications, and drugs requiring refrigeration or special handling. And finally, ADCs improve the ability for healthcare organizations to track the chain of custody of medications through detailed tracking and audit trails that document every medication transaction from dispensing to administration. Overall, ADCs serve as a cornerstone of modern medication distribution, integrating safety, efficiency, and security into daily workflows. As the use of automated dispensing cabinets continues to expand across healthcare settings, standardized best practices are essential to maximize their safety and effectiveness. The ASHP guidelines on the safe use of automated dispensing cabinets provide critical recommendations to ensure medications are stored, accessed, and dispensed in a manner that promotes safety and minimizes risk. Let's go over some of the key areas addressed in these guidelines. The first is stocking and dispensing practices. The way medications are selected, stored, and organized within an ADC plays a major role in ensuring safe dispensing. Medications should be strategically placed to minimize the risk of selection errors. High-risk medication should be kept in locked lidded bins when available, and look-alike sound-alike drugs should be stored in separate areas to reduce the risk of confusion. The use of the override function is another area of focus for these guidelines. While overrides allow for rapid access in emergent situations, uncontrolled or excessive overrides can increase the risk of medication errors and drug diversion. Best practices recommend that override lists be carefully curated, with high alert medications requiring additional safety checks before retrieval. Evaluation of the alerts deployed on ADCs is another area of focus within the guidelines, as ADCs can generate real-time alerts that help prevent errors and reinforce best practices. So you may want to consider how you're deploying these alerts and how those alerts deployed at the ADC contribute to your overall strategy for alerting across other medication use technologies. The fourth topic covered in the guidelines are the safe configuration of ADCs. Proper programming and configuration of ADCs are key to restricting unauthorized personal access, preventing improper medication loading, and enhancing security measures. So this includes things like user access restrictions based on their user roles. It can also include programming and configuration settings like the total number of input characters required before removing a drug on override. The fifth area of focus is on inventory selection and optimization. Determining which medication should be stocked in an ADC and in what quantities is crucial for patient safety and operational efficiency. The selection process should be guided by factors such as medication use and medication utilization patterns. And then finally, drug diversion and surveillance. Given the increasing risk of medication diversion, automated dispensing cabinets play a crucial role in tracking medication movement and identifying suspicious activity. While automated dispensing cabinets offer significant safety and efficiency benefits, they're not without risk. Understanding and addressing potential vulnerabilities in their use is crucial for maintaining medication safety. So let's explore some key areas of risk and how they can be identified and mitigated. We'll start with overrides. So automated dispensing cabinets include an override function that allows medications to be accessed before pharmacist verification. And this is in place primarily for emergent situations. Excessive or inappropriate use of overrides can increase the risk of medication errors. And so to assess override-related risks, you might want to think about how you conduct a regular audit of overrides. These reports should look to identify patterns and areas of highest risk with overrides of things like high alert medications. You might want to ensure that there are clear policies in place and that there's a structured process for reviewing which medications are added to your automated dispensing cabinet override list. When we look at storage of high alert and lookalike medications, this is another area of risk that medication safety leaders should be involved with. The physical organization of medications within ADCs is a critical factor in preventing errors. High alert medications and lookalike sound-alike medications should be stored in a way that minimizes the risk of selection mistakes. And so while it is ideal and best practice to use locked lidded bins, we recognize that that's not always a possibility, especially the case for things like larger infusion bags, like heparin infusions. So here, coming up with a strategy that uses either other clearly labeled bins or other labeling strategies is really critical to ensure that risks associated with storage are addressed. You also want to be considerate of other medications and other drugs that look similar when looking at those storage units that can't utilize locked lidded bins. Barcode restocking data is another source of data that can be used to assess risk. Accurate medication restocking is essential to preventing dispensing errors, and so barcode scanning is used to reduce the risk of stocking the wrong drug in the wrong location. But we really need to be evaluating compliance with scanning protocols to ensure that it's being done appropriately. We can review scan compliance reports to ensure medications are properly verified before placement, and investigate instances of manual override or mismatches between the system records and physical inventory. Finally, critical medication stockouts is another area of risk that can be evaluated by those working in medication safety roles. Stockouts of time-sensitive or emergency medications can lead to delays in patient care and increase risk of adverse outcomes. Understanding which medications are frequently out of stock and why can help drive solutions to prevent future stockouts. So to mitigate risks here, organizations should monitor ADC inventory reports and identify patterns of critical medication stockouts. You can implement par level adjustments and proactively replenish stock before it runs out, and establish routine ingrained workflows to address these needs. Now that we've covered automated dispensing cabinets, we'll shift to another dispensing phase of the MedUse system technology that offers a wealth of data to evaluate risk from. Sterile compounding presents a unique challenge in the medication safety realm. Unlike other areas of medication preparation, errors that occur during IV compounding are often difficult to detect and have a high likelihood of reaching the patient. So given the complexity and risk associated with IV compounding, technology plays a crucial role in minimizing errors and ensuring patient safety. Several advanced technologies have been developed to enhance accuracy, standardization, and safety in IV compounding. And these tools help to reduce human error, improve process verification, and enhance documentation. So some of the most commonly used technologies include automated dispensing devices. So these are machines that assist in the precise preparation of compounded sterile products by automating the measurement and mixing of ingredients. These are often used in preparation of things like TPN, or parenteral nutrition. We have IV workflow management systems, which are software-driven systems that incorporate safety checks such as barcode verification, photo capture, or gravimetric analysis to ensure that the correct medication volume and concentration has been prepared. And also IV robotics. And so while this is still in somewhat early stages of adoption, Uh, Robotic systems can provide fully automated, enclosed sterile compounding to enhance accuracy and minimize contamination. And so there's varying levels of adoption of these technologies across pharmacy practice. When we look at the current usage rates, it highlights a mix of highly adopted tools and emerging technologies. So barcode scanning is certainly the most commonly used technology, where it's been implemented in over 50% of hospitals that responded to ASHP's most recent survey of health systems practice. We can see following barcode scanning, photo capture is used second most commonly in IV compounding as a means of detecting errors in preparation, followed by gravimetrics. When we look at overall utilization of IV workflow management systems, you can see that 31% of all respondents to this survey have adopted this technology, and slightly higher, 37% of respondents have no IV workflow technology in place. And then finally, we have a percent of respondents who are using robotics. So we can see that the adoption of IV compounding technology is sort of all over the board, mostly skewed towards the lower end of adoption at this point. So despite still emerging use of these technologies, both ASHP and ISMP have issued recommendations and statements to advocate for their use. The first, ASHP's policy on verifying compounded sterile preparations, advocates that health systems adopt automation and information technology to facilitate in-process and final verification of compounded sterile preparations. And ISMP's targeted medication safety best practices states that when compounding sterile preparations, perform an independent verification to ensure that the proper ingredients are added, including confirmation of the proper amount, volume of each ingredient prior to its addition in the final container. As these policies and best practices continue to evolve, adopting automation, workflow management systems, and independent verification measures is certainly going to be critical to ensuring the highest level of quality control and patient safety in IV compounding. So as we continue discussing sterile compounding safety, it's essential that we highlight IV workflow management systems. These systems play a critical role in reducing errors, improving standardization, and ensuring accuracy in IV preparation. And given the challenges in detecting compounding errors, IV workflow management systems offer several key safety benefits. First is that they can confirm the correct supplies via barcode scanning. Here we ensure that both the ingredients used, which include medications and diluents, are the correct ingredients before compounding is initiated. We also can standardize the compounding procedures used. So here, these systems can be used to guide pharmacy staff through a structured workflow, which reduces the risk of process variation and human error. And we can also ensure accuracy via photo capture or gravimetric measurement. Here we can use visual confirmation of each ingredient that's been added, or use precise weight-based calculations to confirm that each component is accurately prepared. Some considerations for the safe and successful implementation of these systems include areas of operations and workflow design, safety and regulatory considerations, and then also information systems and the equipment. And so from an operations and workflow design, the integration of IV workflow management systems should be aligned with existing pharmacy workflows to ensure efficiency. And there's a whole kind of consideration of how to successfully incorporate these into your IV room's workflow. From a safety and regulatory standpoint, these systems should align with and ensure compliance with existing regulations like USP 797 and USP 800 standards, as well as any institutional and regulatory guidelines for sterile compounding. And then finally, from an information systems perspective, seamless integration with existing electronic health records, automated dispensing cabinets, and infusion pumps is essential for a cohesive medication use process. And so, again, just to reiterate that as the adoption of IV workflow management systems continues to increase, these technologies are going to be valuable tools in minimizing errors, enhancing accuracy, and improving overall compounding safety, and that by incorporating known and reliable safety systems like barcode scanning and volumetric and gravimetric verification, these systems will provide critical safeguards that support both technicians and pharmacists when preparing sterile preparations. So let's turn now to some of the risk identification opportunities for IV compounding technology. And as we explore risk identification in IV compounding, it's important to recognize that errors in sterile preparation can be difficult to detect and have a high likelihood of reaching the patient. So this makes real-time monitoring and data collection essential to ensuring medication safety. A lot of the areas of data analysis that can be done with these are already intercepted errors, and these are really critical to informing future workflow and safety check and safety design considerations. And so the first area of focus that we'll look on from a medication safety and technology data opportunity is intercepted errors and rejected doses. So one of the most valuable aspects of IV workflow management is the ability to detect and prevent errors before they reach a patient. And so tracking the number and types of intercepted errors provides insight into common failure modes, which can help organizations refine their process and also help in terms of staff training. Another area of data that should be evaluated for organizations using these systems are those preparations made while bypassing the system. So occasionally preparations are going to have to be made outside of the IV workflow management system, either due to some system limitation or urgency of a situation and needing to kind of work around the system. But we really should be monitoring how often and why these bypasses are occurring, as it is crucial in identifying gaps in workflow adherence and ensuring that safety checks are consistently performed when compounding IV medications. And then finally, we can look at barcode scanning compliance. As we know, barcode scanning is a foundational safety step in these types of systems, and verifying the correct ingredients through the use of barcode scanning as opposed to human dependence on identification is really critical. Compliance with barcode scanning protocols should be routinely monitored so that if there are trends in the compliance rates, they can be intervened upon. And an example there would be if we were to see a drop in compliance rate, that might indicate workflow inefficiencies, training gaps, or workarounds that are being done that might compromise patient safety. So ultimately, all of these are great areas of focus for those working in medication safety roles. A lot of this would be in close partnership with pharmacy informatics teams and pharmacy operations teams to really scrutinize the data that you have available to you to enhance your ability to see and identify where there might be risk within your workflows. So to highlight these ideas, what is shown on this slide is a recreation of a dashboard from an organization where IV compounding technology was utilized, specifically an IV workflow system. And we'll start in the top left corner, which shows a view of bypass labels. So these are labels that were prepared outside of the workflow software system. What we can see is along the first column are several hospitals within the broader health system who've implemented the technology. And working our way across, we can see the total number of bypassed labels, the total number of medication orders, and a rate or percentage of labels that were bypassed. And so this gives us a pretty good picture of how often the system is being used, which reinforces the safety elements. And so while this is a very high-level view, it does give us some initial indications of areas of focus. We would certainly want to take a look at site OP, which has a bypass rate of 48%, and really want to understand why they're working around the system almost half of the time. But ultimately, the bypass labels is only going to get us to a certain point. We're only going to be able to evaluate a certain level of risk. And so some other areas that we might want to focus are things like rejected doses and intercepted errors. So rejected doses versus intercepted errors, these two categories are somewhat similar. The kind of key distinction that I would make is that rejected doses might be rejected before the final preparation is completed, whereas an intercepted error is often being flagged by the pharmacist performing final product check and is representative of a compounding error that, had the technology not been in place, may have escaped the system and gone to the next step for the nurse to administer. And so again, you can see here that we have visual of each of the sites within this health system and the number of doses rejected or the number of errors intercepted set against the doses that were prepared, so that rates of each of those rejected doses and intercepted errors could be evaluated. And so these are really good data for, again, medication safety leaders to be partnering with informatics and pharmacy operations folks on, as it'll really help you understand areas of risk that exist within your compounding suites. So when we look at some of the other areas of focus that this dashboard displays is the top categories of intercepted errors. So doing another level of drill down to look at maybe a particular process step or rationale for why a preparation is being has an error might give us specific areas of focus. And also on the lowest portion of the right-hand side of the page is some examples of intercepted errors where we can see a look-alike, sound-alike name pair, levofloxacin versus levetiracetam. We can see wrong volume or wrong dose of a drug added to an IV bag with insulin preparation. And we can see a drug that was reconstituted with the wrong diluent amount. And so all of these are excellent examples that individually are representative of errors that are intercepted. So really great things to highlight and showcase in terms of the value proposition of these software systems, but also over time can be trended to identify ongoing risk that exists within the IV compounding space. So now we'll shift our focus to barcode med administration, or BCMA. This is a widely adopted technology that plays a critical role in reducing medication administration related errors. When used as intended, barcode med administration helps to ensure that the right patient receives the right medication and that that's given at the right dose, the right time. This system serves as an additional safety net in the med use process and complements other error reduction strategies, such as those deployed upstream during prescribing, such as CPOE and clinical decision support, and kind of in concert with and downstream with infusion pump devices. So studies have shown that BCMA implementation can significantly decrease medication administration errors, and particularly those related to wrong drug, wrong dose, wrong time, and wrong patient. However, as with any technology, BCMA is not without its challenges. We have workarounds or deviations from intended use, which can introduce safety risks that compromise the system's effectiveness. These workarounds often arise due to workflow inefficiencies, time pressures, and system design limitations, and understanding them is really key to enhancing BCMA safety and optimizing its integration into daily practice. So some of the examples of workarounds that we may want to be thinking of when considering barcode med administration is just purely overriding a barcode. Here we might have situations in which maybe the barcode is not scanning, that is causing a lot of overrides, really looking into the reasons why medications are being overridden is critical to ensuring users have faith and trust in the system and use the system as designed. While there are situations where override is necessary, potentially an emergent situation where you wouldn't want to stop to slow down to administer medications as part of ACLS, there's the excessive and inappropriate overrides are really where our opportunities for risk identification is strongest. Another workaround that is a source of medication safety risk is with batch scanning. So something you might see here is that instead of scanning medications at the bedside before each administration, all medications that are due, let's say at 9 a.m. MedPass, might be scanned in concert in the med room prior to going into the room, or even at the bedside, scanning all the meds that are being given and then administering them. And this really increases the likelihood of error and really the inability to detect some potential errors that might occur by doing this batching process. We also see workarounds where medications are scanned after administration, and which is defeating of the purpose of using this technology feature, and may itself help in identifying that an error has occurred, but is really working around the system. And then finally, proxy barcode labels. So we see things like this where there may be barcodes that are duplicated and taped to a workstation on wheels, or added to the back of someone's badge so that they can scan and not actually have to scan the product itself. So just another example of a workaround that are areas of risk that might be something you'd want to look at within barcode med administration. So now that we've discussed the benefits of BCMA and some of the risks associated with workarounds, let's shift our focus and we can talk about BCMA-related risks and how to identify some areas for improvement. So a key advantage of BCMA is that it generates a wealth of valuable data that can be used to evaluate compliance, detect patterns, and guide process improvements at various levels within the healthcare system. To effectively assess risk, organizations should leverage system-generated reports to evaluate BCMA performance, and can do so at a variety of different levels. So this might be at the health system level, a hospital within a health system, or even patient care levels. These reports provide insight into medication administration scanning compliance, helping to identify trends, deviations, and potential vulnerabilities when BCMA is used. So some of the key areas and data points to focus on would be patient ID and medication scanning compliance. We would want to be ensuring that both patient wristband and the medication barcodes are scanned before administration. And here, compliance rates can help pinpoint areas where scanning adherence is strong or lacking and allow for targeted interventions. From a medication standpoint, we'd also want to be looking at top non-scanned or failed scanned medications. Certain medications may be frequently omitted from scanning due to packaging issues, system errors, or workflow barriers. And so identifying these medications can help organizations address systemic issues, and whether that means improving barcode placement, enhancing technology functionality, or providing additional staff training. These are areas that we can focus on. And then finally, looking at top and bottom performing users. So BCMA compliance data can be reviewed at an individual and unit level to identify staff members who may need additional training or workflow support. But it also provides an opportunity to recognize high-performing users, which it also provides opportunities to highlight some best practices and promote peer-to-peer learning. Some other areas of risk to think about is with BCMA is evaluating utilization in some non-traditional clinical areas. And so these might be areas that within your organization you haven't implemented fully barcode med administration, but would be areas to think about. So here we can think about perioperative and procedural areas. In surgical and procedural settings, medications are often administered at a fast-paced, high-acuity environment where traditional BCMA workflows may not always fit. And so understanding how BCMA could be used within these settings is really paramount to helping to drive safety improvements. We can also think about areas like ambulatory clinics where many outpatient settings have shifted to using BCMA. However, adoption across all organizations is still varied, and so assessing BCMA use in places like infusion centers, specialty clinics, and other ambulatory clinics is a great area to focus on assessing where risk with respect to medication administration might exist. So again, by leveraging data insights across different care areas and across different data elements, healthcare organizations can identify risks and target interventions to enhance the effectiveness of their BCMA systems. And so we'll pivot now and we'll look at an example of a BCMA dashboard. So here we have a reproduction of a dashboard that is developed for a unit level dashboard for a surgical ICU for the month of January. We can see that this organization of this dashboard has insight into hospital-wide scanning metrics as well as unit level scanning metrics, which are trended over the last several months. And that's located in the upper left corner. So we can see the hospital level patient and hospital level medication scanning, and then also that for the particular unit in question as a way of comparing unit performance to hospital-wide performance. On the lower left panel, we have the medications with the lowest scanning compliance for the unit during this reporting interval. And so we can see a few examples of the types of drugs that are have low scanning compliance. And these percentages might drive us to kind of really dig in and investigate why something might be administered at such a low rate, or and send us in different directions. So with Magic Mouthwash, that 0% scanning compliance potentially indicates a problem with the barcode or the lack of a barcode, whereas some of the other ones where there are clear evidence of the medication being scanned, but maybe not at a compliance rate that we would be targeting, might be evidence more of workflow or training deficiencies. But each of these would give us the opportunity to investigate some of the highest percentage of non-scanned medications. And then we can see over on the right side of the screen our area-specific user compliance. And something you'll note here is that in this particular unit, we have examples of both nurses and respiratory therapists who are administering medications. I think really important to think about the other types of health disciplines beyond nurses who might be administering medications, and how to get the data from your BCMA systems back to the leadership of those areas so that they can both work on performance improvement plans with you, but also celebrate and highlight those with stellar scanning compliance, as evidenced in the lower panel of users with the top BCMA compliance. So now that we've done a little bit of an overview of BCMA and some ideas for how to measure BCMA data and use it, let's pivot now and we'll cover smart infusion pumps. So as we continue exploring medication use technology, our next focus is on smart infusion pumps, which play a critical role in reducing administration errors and improving infusion safety. These devices, when equipped with a drug library and dose error reduction systems, or DERS, provide real-time safeguards to help prevent medication errors and ensure that intravenous medications and fluids are administered safely and accurately. We'll go over a few quick definitions so we're all on the same page. So drug library is a comprehensive list of medications and fluids that are to be delivered using the infusion pump. This library includes any dose, volume, or rate limitations that are programmed into the software. And then a definition for DIRS is software built into intelligent infusion devices that is designed to catch dosing or administration errors. It represents the programming of minimum and maximum dose limits in an infusion pump and the alerts presented to the clinician when programmed doses are exceeded. I'd like to introduce a few additional concepts related to infusion pumps. First, that there are different types of infusion pumps. It's helpful to understand that different types of pumps serve different distinct clinical purposes, with each pump designed to ensure safe and precise medication delivery tailored to the patient's needs and care setting. Large volume pumps are used for continuous or intermittent infusions and include things like IV fluids, antimicrobials, and vasopressors. These can commonly be found in the acute care setting, such as hospitals, but also can be used in ambulatory infusion settings for administration of chemotherapy. Syringe pumps are designed for small volume infusions and are often used in care settings like pediatrics and neonatology, as well as in other perioperative settings and OR settings where administration of medications like opioids and vasoactive drugs are delivered via syringe. Patient-controlled analgesia, or PCA pumps, allow patients to self-administer controlled doses of pain medication with pre-programmed safety parameters for things like dose, intermittent doses, continuous doses, and lockout intervals. And this reduces the reliance on nurses to administer pain medications, which helps provide more immediate relief while minimizing the risk for overdose. Epidural infusion pumps that include patient-controlled epidural analgesia deliver continuous or patient-controlled pain relief directly into the epidural space and are commonly used in care settings like labor and delivery or postoperative pain management. Finally, ambulatory and home infusion pumps are designed for patients requiring long-term or intermittent infusions as an outpatient or in the home. Some examples here include chemotherapy, parenteral nutrition, or antimicrobial agents, which the use of ambulatory and home infusion pumps can enhance patient mobility and independence and reduce hospitalization. A different topic that I'd like to introduce is infusion pump interoperability. One of the most significant advances in infusion pump technology is interoperability, or the ability for infusion pumps to integrate with electronic health records and other medication use technologies. Interoperability offers several key advantages to the traditional mode of programming infusion pumps. First, it reduces the manual programming, cutting down on errors by allowing direct transmission of medication orders from the EHR to the pump. We have enhanced real-time monitoring with infusion data automatically documented in the patient's record, and improved efficiency in workflow, minimizing the time clinicians spend entering infusion parameters. While we won't cover the infusion pump interoperability data extensively, this is a cutting-edge technology that many health systems are looking towards to minimize the potential for errors when administering drugs as an IV infusion. While smart infusion pumps and DIRS play a critical role in enhancing medication safety, risk identification and ongoing monitoring is essential to maximize their effectiveness. By analyzing pump data, we can identify patterns of risk and areas for process improvement. The starting point for data review with infusion pumps is DIRS compliance. We want to ensure that clinicians are consistently using the drug library and that the safety limits in place within the drug library are used rather than bypassing or overriding them. Here, monitoring compliance rates can help us identify gaps in education, workflow challenges, or system limitations that may lead to unsafe practices. The remaining three areas of focus center around the idea of exceeding or attempting to exceed a soft or hard limit that is pre-configured in the drug library. And the examples provided are bolus dose limits, loading dose limits, and rate or dose titration limits. Here, each of these parameters, depending on your pump technology, could be pre-configured within your drug library to set soft and hard limits in which users would receive an alert or be prompted to reprogram based on their attempt to program beyond that limit. With each of these, there are strengths and limitations of each of these, but these are certainly areas of opportunity to look at and evaluate for determining risk associated with infusion pumps. On the next slide, we'll take a look at an example of a dashboard that uses several of these data points to highlight and target risk identification. So here we have an example of that is reproduced from a dashboard that's used to highlight smart infusion pump compliance. We see on the top left section of this dashboard, we have a line chart displaying the percent of DIRS infusion over the interval of time that's being monitored. And we can see that each quarter, the DIRS infusion percent is hovering around 78 to 79%. In the lower panel, we can see the total number of alerts that are being triggered by programming of the infusion pump during the time interval, and is presented as a comparison from prior quarters so that we can see changes over time in the total number of alerts. And while these metrics are really great from a high level, they don't do a great job of digging into some of the specific alerts that might exist. As we look further on this dashboard, we find that there is a chart that displays the overall number of canceled alerts, reprogrammed alerts, and overridden alerts in the lower left. And then we can see a table with the top medications where alerts fired during the reporting interval. I think being able to look and investigate the medications with the highest number of alerts is really important, and one of the areas where risk identification can be kind of narrowed down or drilled down into compared to looking at some of those higher level data points. Additionally, on the right side, we have some examples of some good metrics to track with respect to infusion pump programming. We can see where the DIRS caught decimal point errors, double-digit errors, or high-rate errors, and the total number of intercepted errors that were attempted within each of those categories. And then we have an example table of some good catches that were identified by the utilization of an infusion pump with DIRS. Building on the concept of evaluating your limits, drug library limits, and how users of the pump are interacting with those, this is another way to visually display your infusion pump data. So here we can see trended quarter over quarter for the first 3 quarters of a year are the number of soft limits that were exceeded, the number of soft limits that were reprogrammed, and the number of hard limits that were attempted. And while again this is more of a high level overview, as you drill down into a drug specific view of this or an area specific view of this, you would start to gain more insight into where the risk exists. So all of those soft limits that are being exceeded might represent risk that exists, and if you're able to narrow your focus and kind of drill down to the next level, provides some really good opportunity for not just identifying risk, but focusing your improvement efforts. So here's an example of how you might do that. Presented on this slide is the same graph, but with a table below it that shows a list of drugs and the total number of soft limits exceeded within a single quarter, and the total number of infusions of that drug within that quarter as well. And something I'd like to highlight here are some examples where we see the total number of soft limits exceeding the total number of infusions of a particular drug. And so we can see that for drug A and drug E in this example. The soft limits are firing more times than the drug is being infused. And so what that likely is indicating is that these are drugs that are titratable drugs in which almost every time it's being programmed, the soft limit is being exceeded. So this is one potential way that you might consider looking at your data and investigating whether there's risk here. If you've previously set your soft limits and are finding that there's a lot of infusions that are programmed with where they are routinely exceeding those, you may want to go back and evaluate the protocols that are in place for that drug and really understand if there's risk with all of those programmings. Additionally, this might be a good indicator of alert fatigue that's present, where you need to reset those soft limits to make them more effective for purposes of intercepting and mitigating any harm that might come with a misprogramming of that infusion. So building on that example, we'll drilled into drug A here, where we found that there were more soft limit attempts than total infusions. The soft limit was previously configured at 125 milliliters an hour, and there was a new protocol implemented that allowed for titration up to 250 mils per hour. So every time the nurse programmed, they would have to bypass this soft limit, and that level of detail and analysis led us to rethinking the soft limit that was programmed in the pump and setting it at a new limit of 250 milliliters. And to provide a final example of how you might investigate your infusion pump data to identify risk within your workflows, here's an example of a drug in which there were many hard limits attempted. So these were programmed with an attempt to exceed the hard limit, which is currently set at 40 milliequivalents per hour. In a sub-analysis of the overall hard limit attempts, we looked at 387 hard limit attempts, and we could see that evenly distributed among a medical floor and an ICU, where the majority of attempts were to program at 100 milliequivalents per hour, so exceeding the 40 milliequivalent per hour hard limit. We see that there was one attempt for 500 milliequivalents per hour and one attempt for 1,000 milliequivalents per hour. And so when we look at something like this, there's some kind of clear things that we see. One is that those that are attempting to program 100 milliequivalents per hour are likely thinking of the rate as opposed to the dose of infusion. So the dose of most infusion equates to 100 mils per hour, which is where we suspected those 100 milliequivalent per hour programmings were coming from. And then the other two attempts at 500 and 1,000 are likely representative of a double-digit push, so adding an extra 0 at the end of the programming, and also misinterpreting the dose mode for this drug. And so having an understanding of this really just gives you a lot of insight into how you configure your drug libraries, how users are interacting with the drug library, and might inform some future process improvements. At the end of the day, these hard limit attempts are really great narratives to display and help to highlight the value proposition for using the drug library. And as was displayed on the previous dashboard slide for infusion pumps, really helpful to articulate the true value of using the drug library and adhering to those dosing limits. Now that we've explored key medication use technologies like CPOE, clinical decision support, automated dispensing cabinets, IV compounding technology, BCMA, and smart infusion pumps, let's return to the medication use system as a whole. At the start of this discussion, I introduced an infographic representing the medication use system. And while this doesn't capture every phase in full detail, it serves as a foundation for understanding how medications move through the system, from prescribing to dispensing to administration and ultimately to monitoring. Throughout each phase, we've seen how technology is embedded within the medication processes, how it improves efficiency, standardization, and safety, and how these technologies can contribute to error prevention, guiding of best practices, and providing valuable data that will allow us to assess risk and refine our processes. We've also discussed how technology itself can introduce new risks, from alert fatigue to BCMA workarounds and infusion pump overrides. Key takeaway is this: medication safety isn't just about implementing technology. It's about how we use it and how we monitor it and how we continuously adapt to improve patient care. The data we collect from these systems provides a powerful opportunity to proactively identify risks and to strengthen our safety strategies. And while it is helpful to approach risk by using the medication use system as a framework, because it allows us to systematically assess potential vulnerabilities at each phase. From a systems thinking perspective, sometimes it's important to recognize that these phases are highly interconnected, that no process operates in isolation. And this is certainly true of our technology systems. Technology systems often generate data that span multiple phases of the med-use process. No single data source, such as BCMA scanning compliance or smart pump infusion alerts, can provide insights that extend beyond that phase of the medication use system. So to gain a comprehensive view of risk, sometimes we need to merge data from multiple technologies and multiple sources. So for example, integrating pharmacist intervention records with CPOE alert override data or linking ADC stocking reports with infusion pump utilization trends might be beneficial to really understanding the risks that we're after. By leveraging cross-functional data sources, we can move beyond this siloed risk assessments that we're accustomed to and take a more holistic approach to medication safety, ensuring that our interventions address system-wide vulnerabilities rather than isolated points of failure. While thinking about the risks using the framework of the med-use system is helpful, it's important to recognize that these systems are highly interconnected. A single event, such as a medication error, often involves multiple phases of the med use process, and so identifying underlying risks require a broader systems thinking approach. From a technological standpoint, one way that health systems address the complexity of this systems thinking concept is by leveraging data warehouses, centralized repositories that can aggregate data from various technology platforms, including things like CPOE, automated dispensing cabinets, infusion pumps, and electronic incident reporting systems. And so by merging these data sources, organizations can perform more sophisticated analyses that go beyond what's possible with a single system alone. So over the next few slides, we'll walk through a use case for how we might think about incorporating multiple systems in our assessment of risk. So far, we've discussed how individual data sources, whether from CPOE, ADCs, BCMA, or infusion pumps, might offer valuable insights. But as we've emphasized, medication safety isn't about isolated events in a single phase. It's about understanding how these systems interact and how data from multiple sources can be integrated for a more comprehensive risk assessment. To illustrate this, I'm going to walk through a case that highlights the interconnected nature of medication safety risks and the importance of using data from different technology systems. This example will show how identifying an issue in one area can lead us to uncover broader system-wide challenges and ultimately drive more effective safety interventions. So in this case, a patient safety report was submitted through your institution's incident reporting system and describes a patient who experienced increased sedation following administration of Dilaudid and ultimately requiring Narcan or naloxone reversal. One key detail in this report is that the staff member who submitted it categorized the event as an adverse drug reaction. As we dive into this case, we'll examine how data from multiple systems can help us determine whether this was truly an adverse drug reaction or if other contributing factors such as prescribing, dispensing, or administration errors played a role. This will help us think critically about how to use technology-driven insights to enhance patient safety. So as we take a closer look at this case, additional details provided further insight into what happened. The patient was originally ordered to receive morphine 5 milligrams IV, but instead was mistakenly given hydromorphone 5 milligrams IV, five-fold increase in opioid potency. This error occurred when the nurse removed the medication via an ADC override, mistakenly selecting the wrong drug due to a mix-up between two patients that that nurse was taking care of. Compounding the issue, the medication was not scanned prior to administration, a deviation from standard barcode med administration protocols. And this occurred because the patient was in significant pain, leading the nurse to prioritize rapid administration over scanning. Unfortunately, as a result of this error, the patient experienced opioid-induced sedation and respiratory depression, requiring naloxone reversal. I'll underscore that this case has multiple system vulnerabilities which might benefit from a review of different medication use system technology data. So while we would want to certainly follow up on that specific event report to really understand what happened in that particular case, You might find yourself asking a broader set of questions about what technology data you might be interested in looking at and utilizing to evaluate the bigger risks associated with some of what you uncovered during the course of your investigation. You might want to evaluate how often those risks are occurring without being reported. And so to truly assess the scope of this issue, you might need to look beyond your incident reporting system because you might just not have that many reports of a similar nature. And so you would find yourself questioning what med-use technology data could be utilized to evaluate the risks that were identified in this report. So, for example, we might explore ADC override data to determine how frequently high alert medications like hydromorphone and morphine are being accessed without pharmacist verification. It might cause us to question whether these are appropriate under our policy for ADC overrides. We could also analyze BCMA scanning compliance to assess how often medications, like the two mentioned in this incident report, are administered without barcode verification, particularly in high-risk situations, such as when patients are in severe pain. By leveraging multiple data sources, we can move beyond a single isolated event and work towards a broader system-level understanding of risk, which hopefully would help us to better quantify the risk and to implement proactive safety measures that can help intervene in future situations. So we've looked in a little more depth at ADC override and BCMA compliance and override data as a source of assessing medication safety risks. And while those data sources certainly provide valuable insight into some specific failure modes within the med-use system, oftentimes they're very focused around process and not necessarily directed towards patient outcomes. And so we're kind of left with a challenge that we can look at these findings of cabinet overrides or bypass scans and really still be left with a gap in our understanding of risk. And so an additional methodology that I'd like to introduce now is a trigger-based ADE risk identification methodology. Rather than waiting for incidents to be reported via incident reporting systems or by discovery through rigorous investigation of other data methods like ADC overrides or BCMA scanning, trigger-based methodologies use specific criteria or signals in the electronic health data to proactively identify potential medication safety events. These triggers don't necessarily confirm that an error has occurred, or that an ADE has occurred, but they highlight cases that warrant further investigation. So for example, if in the case we're analyzing, a trigger-based approach might involve identifying patients who receive naloxone after an opioid administration, which could suggest an opioid-related adverse event. By applying this method across a larger data set, we can detect patterns, uncover unreported events, and gain a more comprehensive understanding of medication safety risks at a system level. So let's take a closer look at how we can apply trigger tools and some of the history of trigger tools to better understand so that we can best assess and mitigate medication-related harms. While incident reporting systems provide valuable insight into medication safety risks, they come with a significant limitation. Many adverse events go unreported. In fact, studies have shown that traditional reporting systems may only capture a fraction of actual events, leaving critical safety issues undetected or under-detected. Recognizing this gap, the Institute of Medicine emphasizes the need for additional methodology to measure patient safety, moving beyond voluntary reporting. And several approaches have been developed over the years, each with its own strengths and limitations. So for example, the Harvard Medical Practice Study, this is a study that was utilized as source material for IOM's To Err Is Human report, utilized medical record review to assess adverse events, a method that, while thorough, is highly resource intensive and really not feasible or practical for application as part of routine risk assessment within medication safety programs. Other strategies like HRQs, patient safety indicators, and the Utah Missouri Adverse Event Classification System relied on automated strategies to query discharge codes from administrative data. So while this approach allowed for a really large-scale analysis, there was often a lack of clinical granularity that came with this methodology. And so to bridge this gap, trigger methodology was developed by IHI that aimed to improve the efficiency of identification of patient harms. Here, triggers would be utilized to quantify the severity and frequency of harm and to identify and test quality improvement interventions. So IHI's Global Trigger Tool is a structured manual review process designed to identify adverse events more effectively and provide a more accurate measure of patient harm. So how does this work? The Global Trigger Tool methodology involves randomly selecting a sample of patient records and reviewing them for predefined triggers, so specific indicators that might suggest the presence of an adverse event. These triggers are not adverse events themselves, but rather flags that warrant further investigation. So some examples might be the use of antidotes or reversal agents, as we talked about with our naloxone example. It might be abrupt medication discontinuation, which might indicate the presence of an adverse reaction. It could be elevated laboratory values like a supertherapeutic INR, which suggests bleeding risk, or documentation of patient harm in clinical notes. The process is typically carried out by a team of trained reviewers, often consisting of pharmacists, nurses, physicians, who examine the flagged cases to determine whether an actual adverse event occurred, the severity of the harm, and whether the event was preventable. An important feature of the Global Trigger Tool is that its systematic approach to inter-rater reliability, meaning that different reviewers analyze the same records and ensure consistent identification of adverse events, which helps to standardize the process and minimize bias. Since its development, the Global Trigger Tool has been widely applied in research with quite a few publications. In a study that looked at publications between 2006 and 2014, there were 48 published studies. It's been applied across multiple specialties, including pediatrics, ICUs, oncology settings, surgical settings, which makes it a really versatile tool for identifying harm in different patient populations. However, studies using the Global Trigger Tool have varied in their methodologies, which includes differences in sample sizes, sampling frequency, and incorporation of additional components like preventability assessments. And so these are, while the original methodology had a defined and prescribed approach, a lot of study investigators have adapted that to their institutional needs and to their research needs. Despite this variability, the findings consistently indicate that traditional reporting systems significantly underestimate the true rate of harm, so reconfirming that statement from before. Adverse event rates have been found to range between 7 to 51% of per 100 admissions. So on average, 40 adverse events occur per 100 admissions. And ultimately, this is really a superior method for detecting adverse events compared with incident reporting and even the AHRQ methodology described on the previous slide. The Global Trigger Tool certainly is helpful in identifying significantly more adverse events and often uncovering cases that would have otherwise gone unnoticed, which makes this method a really strong method and one that has persisted over time. And while the Global Trigger Tool has persisted over time, it's been instrumental in identifying adverse drug events retrospectively. Because it was originally designed as a manual process, there's some key limitations there that don't allow for widespread and broad application. So recognizing this gap, researchers and healthcare organizations have sought to develop electronic trigger-based methodologies that can detect potential adverse drug events earlier and enable proactive intervention. The concept of an electronic trigger tool was first introduced by David Klassen, who described an automated approach to identifying medication-related harms using predefined electronic triggers. This methodology was later endorsed by the National Quality Forum as part of its Safe Practices for Better Healthcare Strategies of Progressive Organizations, advocating that its adoption in high-performing healthcare systems was critical. Unlike the retrospective nature of the global trigger tool, electronic trigger tools could potentially work in real time, scanning patient data for early signs of medication-related harm, often before adverse events are fully developed. And so in this sense, offer the promise of more real-time surveillance of patient harms that might be likely to occur. One of the most promising applications of the electronic trigger methodology is its integration with clinical decision support. And so that, again, that surveillance methodology where it integrates with CDS and electronic medical records, where those alerts are embedded in those systems to create an opportunity for real-time intervention. Might be things like trending serum creatinines over time to detect the potential for worsening kidney function and how that might contribute to changes in dosing of antimicrobial agents that are renally dose adjusted. It might be looking at trends over time of patient INRs to provide early warning so that intervention could be made to address patient's warfarin dose. And so ultimately, by combining this trigger-based ADE surveillance with clinical decision support workflows, healthcare systems can begin to move beyond some of the retrospective nature of trigger-based methodologies and integrate those into real-time decision support at the point of care. And so while the advent of real-time triggers is really exciting, one of the areas that we'll focus now in the coming slides and in the remaining examples are still retrospective in nature. I think it's really critical to understand that there is still an immense value in retrospectively looking and utilizing the trigger-based methodology to identify risk and quantify risk within your organization. And so we'll walk through a few examples here using different trigger-based methodologies. And so the first example here is using your automated dispensing cabinet as a trigger to evaluate the potential for harm with opioids. And so running a simple naloxone utilization report out of your automated dispensing cabinet might provide you with enough information to go and investigate these patients' records and evaluate whether there was an actual error in process that could have been prevented, and identify kind of your widespread opportunities for improvement. So building on that concept, while using automated dispensing cabinet data might be a good starting point, just removing of a drug doesn't necessarily convey that it was administered, and so you might want to make that review process a little bit more efficient. And so here is an example of using administration data. So similar concept. Here we're using the example of dextrose 50%. And looking at administrations of D50 in patients in an inpatient setting. So here we can take a look at generating this report out of our electronic medical record. And this is just another way of using D50 as a trigger. D50 is a kind of traditional trigger that would be something like the IHI methodology of using reversal agents or antidotes as a trigger for potential harm from insulin therapy. And here this might provide us with a sampling of patients who receive D50 and allow us to focus our efforts around safe insulin practices, because we have a better understanding now of the risks associated with insulin use. So now we're going to take that even a step further, and I'll use the concept of data warehouse and how data can be organized within a data warehouse and then used to generate triggers that, in this case, generate an email notification. So the example here, we're back to naloxone as an example, in which the way that this report is configured is that patients who receive naloxone are kind of the entry into qualifying for hitting this report. But not just did they receive naloxone, these patients also had to have received an opioid within a defined period of time while in the hospital, further helping to narrow down the cases that we are most interested in reviewing. And so these cases don't represent all naloxone utilization for the organization, but rather those naloxone cases where we are particularly focused and want to be assessing risk associated with our opioid prescribing practices and opioid use practices. Certainly there's value in looking at all naloxone, dependent on whether that's naloxone that's needing to be administered perioperatively, whether that's naloxone that's administered in the emergency department. But if we really want to focus our efforts using a data warehouse where you can build additional rules, like did the patient receive an opioid? Was that opioid administered within the last 2 hours? Was that opioid administered while the patient was inpatient? Can help to build upon and narrow your focus to be better able to evaluate your risk. The last example that I'll provide here is more of a visualization of a trigger-based methodology, and this example is looking at hypersensitivity reactions in an ambulatory oncology infusion practice. Hypersensitivity reactions can range from mild responses to more life-threatening anaphylaxis, and if we look at the range of therapies provided in an ambulatory oncology setting, certainly those medications come with a high risk for hypersensitivity. And so this example uses a few different trigger-based methodologies. So the first is a report in our institute's safety event reporting system. And so if a report is filed, it would qualify for inclusion in this data visualization. But we also take that a step further and utilize some triggers from the medical record itself, specifically how nurses are documenting the management of hypersensitivity, but also things like the administration of epinephrine or drawing of a lab. In this case, there are some specific oncology-focused labs that are drawn that the oncology team and the allergy team want to be evaluating. And so by narrowing your focus on some of those specific triggers and including cases that meet those criteria, you're able to pinpoint and narrow your focus and increase your capture from traditional methods like incident reporting. And so here, these data are all integrated in an enterprise data warehouse and then ultimately integrated with a data visualization tool like the software that's displayed on this slide. So here we can map specific medications, identifying trends and drug-related hypersensitivity. Using tools like the one shown here allow us to filter the data much more easily and pinpoint specific site hypersensitivity rates, look at drug-specific hypersensitivity rates, be much more nimble in our evaluation of the risks that exist, and ultimately identify the risks that have the potential for process improvement and intervention potential.
So to summarize the trigger tool methodology, provided here are some guiding principles for their use. First, we want to define our objective and really understand what we're attempting to isolate with a given trigger. Before implementing, it's crucial to define clearly what we're looking to detect as a well-defined objective helps to ensure that the selected trigger aligns with the clinical question we're trying to answer. The second is that validating triggers based on local practice norms is really crucial. Not all triggers are going to function the same way in every organization. And this is driven based on medication use practices, documentation workflows, and even the way that clinical decision support systems are configured across health systems. And so validating triggers within the context of local practice norms can help to ensure accuracy and relevance. The third is that iterative refinement and that triggers are really need to be evaluated on an ongoing basis. Trigger-based surveillance, it cannot be a static process. Instead, we've got to look to refine them and improve so that we can improve their sensitivity and specificity. False positives or cases where triggers are identified, even though there isn't a true safety risk, could lead to a lot of wasted resources evaluating those. And that ultimately through this kind of iterative process or continuous monitoring and refinement, we can improve the positive predictive values of triggers so that we can focus on clinically relevant events. The fourth principle is that we should look to leverage our EHR and, where available, our data warehouse resources. Certainly, traditional manual review is a great place to start, but this methodology of auditing charts is really resource intensive and can be quite limiting in terms of the scale of records that can be reviewed. And so utilizing electronic means to query medical records is certainly a great way to increase capture and when available, to be able to couple multiple data systems through something like an enterprise data warehouse can provide a broader data set for analysis. And then finally, enhancing trigger precision by coupling medication triggers with other clinically relevant criteria is really important, as we described in a few examples with naloxone, with dextrose, even in the last example with hypersensitivity monitoring. Medication-based triggers alone might lack the specificity that's needed to differentiate true adverse drug events from expected therapeutic responses. And if we're able to couple our medication triggers with other clinical criteria, we can significantly improve the positive predictive value of their use. And so with that, we will now pivot back to our self-assessment question.
So returning to that self-assessment question, we'll ask, which of the following best exemplifies a systems thinking perspective? Here, the correct answer is B. Analyzing ADC overrides in combination with BCMA data and naloxone administration records exemplifies a system thinking perspective. This approach considers multiple interconnected data sources across different phases of the med use system. By integrating these data points, the team can identify broader patterns of risk, uncover system-wide issues, and hopefully develop targeted interventions to improve medication safety. Answer choice A, which is reviewing barcode administration data and override rates to determine a health system-wide scanning compliance, is incorrect because while BCMA compliance is important, evaluating override rates alone does not provide a comprehensive view of risk. Context matters, and it's critical to assess why overrides occur and how they relate to other safety concerns. C, investigating an adverse drug event report submitted through the incident reporting system is incorrect because investigating a single report is only capturing a fraction of medication-related errors and often underrepresents the true scope of harm. A system thinking approach goes beyond an individual report by leveraging automated data sources and applying methodologies like trigger tools to proactively detect risk. And D, evaluating CPOE alerts is incorrect because monitoring provider responses to alerts without considering patient outcomes may lead to misleading conclusions. Some alerts might be overridden appropriately, while others might indicate missed safety interventions. A systems-based approach here would incorporate medication monitoring data, patient outcomes, and workflow analysis to better understand the impact of CPOE alerts.
So as we wrap up this discussion, I want to emphasize a few key takeaways regarding the role of technology data when it comes to identifying medication safety risk. It's important for med safety leaders to be members of the teams that are responsible for managing med use technology systems. These technologies are not just operational tools, but are critical components of medication safety. And to ensure that these systems are optimized for patient safety, med safety leaders really must be actively participating in their management and part of the interdisciplinary teams that oversee implementation, design, and ongoing risk assessments. And definitely as part of that is the evaluation and evaluation of the data that is generated from them. Technology-generated med safety data exists within most phases of the med use system. As we discussed throughout this presentation, there's data availability in practically every step of the med use cycle, from prescribing to verification and preparation, dispensing, storage, administration. There's a wealth of data that's available, and one of the major themes that is discussed in this module and in others is that medication safety risks are rarely isolated. Because data exists within nearly every phase of the med use system, it's really critical that we think about this in the context of other risk identification methods like event reporting or prospective methods like safety rounding, as these data can help provide a more comprehensive picture of our medication safety risks. And then finally, that in combination with other risk identification methods, med safety leaders should be able to interpret and utilize data generated by these technology systems to optimize their med safety efforts. While the availability of data might be a strength, it can also be overwhelming. There's a wealth of information that's waiting for us to be able to evaluate, and really taking a more manageable approach by looking and taking smaller steps towards a broader goal of incorporating technology-based risk identification into your broader medication safety programs is really critical. Ultimately, the goal is not only to really detect risks, though, it's really to drive change. And so by integrating these med use technology data strategically and ensuring that med safety leaders are at the table, we can create safer medication use systems and ultimately better patient outcomes.
These are the references used to develop this presentation. Thank you for your time and participation.